Okay. Welcome, everybody. I'm Rebecca Berman. I am helping to moderate this evening's discussion with our esteemed host, Glenn Grossman. Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff in the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs in the United States and abroad. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. We are very lucky once again to be hosted by our very own Glenn Grossman. So welcome to everybody who's in the audience with us live and those who are watching on YouTube. Let's jump right in, Glenn. What's happened this week? I think I have a sense from what I've been watching, both in the US and abroad. So take us around the world.
Hey, Beck, thanks for your introduction. It's great seeing you and everyone else again this week. All right, let's see. So let me share my screen. All right, pause share. Okay, so here is where we are. So we have entered the official cold and flu season, the typical cold and flu season. And what that means is that now we're seeing normal respiratory viruses start to get more contagious and to spread more. So we've talked about this previously. I'll just quickly go through it again for people who might be new to the conversation. So you see that there were essentially 3 surges so far. The first surge was back in March and April, although the diagnostic tests were a lot less readily available. So the diagnosis rate was much lower. So even though the number of cases appeared lower, what we're seeing there in pink, it was actually likely to be higher than the second surge that we saw in August. Or to at least to it was maybe if not higher, it was quite strong. When you look at currently hospitalized, we had those 2 peaks, the first surge and the second surge, but that's kind of deceiving. So in the first surge, the length of stay at the hospitals, the average length of stay was much longer than it was for the second surge. And so even though the second surge and the first surge had the same total peak and the area under the curve seems roughly similar, there were far, far more people hospitalized during the second surge just because they were in and out of the hospital in a few days for many people, instead of back earlier where they might have been in there for longer, for weeks maybe. And so if you look at any given day, so we're looking at like currently hospitalized, that means any given day, then the peak number roughly hit the exact same point. But if you look at the total number of people who are hospitalized at any point during that period, then it would have been more for the second surge. And also when you look at the deaths, the number of deaths reduced by around half. And you can just see that from the peak in April to the second surge when you compare those two peaks. And the primary reason for that, there's a couple reasons. The 2 main reasons that I see are 1, people who got sick tended to not be as severe. And so one of those reasons is that the dose makes the poison. And the thinking is that people who have a larger initial dose of exposure, their immune system has to ramp up much more rapidly to get control of the virus. And so that leads the immune system on that path of just overreaching and the immune system going out of control. Whereas if it's a very small infectious dose at the beginning, it's much easier for the immune system to get on top of it without getting out of control. That's one theory. The other thing that we're that could be driving this is that we got tremendously better at responding to or using the available treatments and optimizing them for patient care. So for instance, the use of dexamethasone, which is and other corticosteroids, which dramatically reduce the immune response. The use of oxygen, keeping people on oxygen, not having them go on ventilators until the last possible moment. even turning people in their beds, doing other types of things that we've realized over time, it had a remarkable difference that's very apparent. Now we're entering the third surge, and so you see that we're having the uptick in cases again. We're having the uptick in hospitalizations, and the death rate, which had been going down, has now leveled off and will begin to start rising again as well. And so, I mean, it's just a matter of time. The deceiving thing here, let me click down a little bit. So, well, first of all, here's a good view. Let me see if I can find it. State cases, this one. I like this view. I don't know if we've seen this one in a while. All right, so this is the day, or the day that each state recorded their peak number of cases. And so you see that there's wide variation. Instead of there being one United States outbreak or one United States epidemic, it's really like there's dozens of epidemics in the United States, and each of these were occurring on different times in terms of when they hit their peaks. And so as a result, when you look at the average doesn't look so bad because the United States, let me see if I can get to the average real quickly. That's not what I want. Yeah, this one. So when you look at the totals, let me get rid of France for 1 second. Well, I'll keep France. So the United States, on average, you see that the number of cases never really exceeded 200 cases per million. And so that doesn't seem so bad when you compare us to other countries like Brazil and other countries. France looks like they're an outlier, doing quite poorly right now. But then when you look at specific states, and so here I will come to specific states, what you find is that specific states actually hit way more per million. So back in July, there's Florida. It hit over 600. It had one peak day, but on average, that the density of the peakness was closer to around 600. I had one day where it was, or a few days where it was approximately 600 cases per million people. And so this was all average because the peaks were happening all different times throughout the last 9 months. And so as a result, it made the United States seem better. What's different now is that all the states, except just a couple, and all the regions are now going up at the same time. So what this means is that this next third surge is going to be the biggest that we've seen because it's going to be all the regions on top of each other. So you see, like the Northeast, when it had its first surge back in March and April, and through early June, that was very different. So the weighted average made it so it didn't seem so bad. But now, as we enter November, December, January, February, all the peaks are going to overlap. And so the peaks are going to get really big, and there's no way to avoid it at this point. Well, there is, I mean, using masks, locking down, those kinds of things. But if we continue on the current trajectory, my point is that there's no way to avoid it. So what we require is a change in the way that this disease is managed in the United States. And so we need to have mandatory mask wearing and the other contact tracing and testing and all the things that we talked about before. But things are going to get rough in this winter period, and there's no way around it in some ways now. Because we never got the disease under control in the United States, we're sort of locked in at this point to the coming months, and it's unfortunate. When we look at hospitalizations, that too is already starting to increase in all regions. In the West, it's not increasing as rapidly. It's already starting to increase more rapidly in the South. In the Midwest and the Northeast is seeing more increase in hospitalizations versus what we had in the prior 2 or 3 months. And so yeah, this is tough. The next thing that we're seeing, so the reproductive rate, we haven't talked about this in a while. So this is on average how many people get infected for every one person who's contagious. And you can see that this is rising. So for instance, when you look at a lot of states, green was below 1. If it's below 1, then that means that it's reducing. If it's above 1, then it's red, and that means it's spreading. And so it's the rate of spread. And so you see that in most states around the country, the rate is going up above 1. So it's becoming more and more contagious. or rather than contagious, it's becoming more and more, it's spreading at a higher rate. Um, I use contagious to refer to the virus itself, just in terms of how much it's likely to spread, just based on the viral and patient interactions, whereas the rate of spread at a population level is more related to this R value. And so that's one of the things we've talked about previously, that the virus itself will become more contagious over the winter months, not necessarily because of the RNA changing or the genes or the virus itself mutating, but simply because the virus, it's easier to spread when there's less humidity, when people spend more times indoors, and so just because it's so cold outside, for a variety of these other kinds of reasons, it's much easier for the virus to spread, and it's essentially more contagious as a result. Um, and so you see that around the country, we've started this uptake, and it's only going to get worse. We'll talk about it more. There's some interesting projections that have taken place. Um, One other thing, I'll just go through some of the dashboards we haven't looked. So much of the country now, so orange here is at risk of an outbreak. We're right on the edge of really starting to see the outbreak start to really get steroids. What we saw in the South was that the coronavirus outbreaks really took on, it was as if they were on steroids. That was their winter in the Southern Hemisphere, not the United States South, the Southern Hemisphere, where they just got out of their winter. It was like COVID-19 on steroids. And that's what we expect for the Northern Hemisphere in the coming months. Right now, here's the snapshot. Let me go back to this other snapshot. No, that's not it. So this dashboard also largely red or dark red. The only two states, according to this dashboard, that are doing pretty well right now are Maine and Vermont. But so right now they are doing great. But like I said, the flu season is going to be it's not flu. The flu respiratory illness season that's coming upon us is going to be particularly bad this year with coronavirus. And so the types of geographies that are more adverse and that make people go inside more, and where the weather tends to be drier in the winter, that is these regions in the further north. So it's going to be really hard for these states to make it through without changing their management and having more severe constraints. Is there anything else I want to talk about? So you can look, I mean, this is just another way of looking at it. This is the New York Times. We've looked at this before. A lot of the states are rising, some states more than others more quickly. Nebraska, South Dakota, Montana, Wisconsin. Some of these are rising a lot more rapidly than others. Some are low but rising. And then there's only a small handful that are low and still managing to stay somewhat low. All right, I will get into this other stuff. All right, Beck, I'm going to send it back to you, and then we can get into the questions. Oh, but before I do that, one more thing. So this is the current projections from machine learning. So the difference between what we just saw, this is cases. So these are diagnosed cases, what we were just looking at, diagnosed cases consistent with what's reported in the CDC. This is hospitalized and deaths. But the key thing is current cases. So current cases we know are not actual infections. They're only diagnosed infections. And so there's some great work that's being done to try to estimate infections themselves rather than the diagnosed cases. And so our best estimate for the total infections is that there were approximately 270,000 people infected. I guess October 5th is the most recent date that they have here. But on October 5th, that one day, 272,000 on that one day. The numbers are rising very rapidly in the United States. Luckily, our diagnostics are much better than they were 9 months ago, but the rates are going to continue. With that, all right, Becky, back to you.
Thank you, Glenn. Thanks for that quick trip around the country. Always useful, though, to see how we compare in different parts of the country against our neighbors. Just to follow up on something we spoke about last week, we spoke about the Barrington Declaration and how unethical it was. And a question actually has come in. Did the US government endorse the Barrington Declaration? What is the US, does the US have an official policy here? And what did the World Health Organization say vis-a-vis this Barrington Declaration?
Yeah, so let's get back into this for a second. So the Barrington Declaration, let's talk about this again real quickly. Um, so the Barrington Declaration was, there were some fringe scientists who authored this, this idea that they would promote this concept of natural herd immunity. So people who are at low risk of severe disease or death, they would encourage them to go out and get infected, or at least to avoid any constraint, and so be willing to get infected, with the idea that the quicker that they got infected, the quicker they would reach some sort of herd immunity, natural herd immunity. And then they decided, well, people who are at higher risk would just have this thing that they're calling focused protection, which no one really knows what that means. But this idea, on one sense, that's intuitive, that means that if the people who are at highest risk, who are over the age of 65 or have this conditions like diabetes that might make them at higher risk, that for those people in particular, we'd somehow protect them. And so they never explained what that meant, but intuitively, they've been using these intuition pumps and rhetoric to say, oh yes, we focus our protection just on them. The problem is no one knows how to do it, and they've not communicated how to do it because it doesn't exist. So the mainstream epidemiologists have started fighting back. I'll get into that a little bit later, but basically, here is the general reason why why it's a fringe viewpoint, and why most epidemiologists are opposed to it. One, herd immunity has never been found in any other coronavirus. So the a common cold virus is a coronavirus. There's a few coronaviruses circulating in people, and because the symptoms are so mild, you can look at blood samples over time and just look to see if natural herd immunity has occurred, because people typically wouldn't dramatically change their behavior for a cold. And so you could see the natural behavior of the virus to see if herd immunity was achieved. It's never been found to be achieved. One study in particular that was looking at it followed a group of people over 6 years, or a community over 6 years, and herd immunity was never reached over that 6-year period. The second thing is that people have been confirmed to be reinfected with SARS-CoV-2. Some people on reinfection have been more severe, and one person even has died with their reinfection, even though they only had mild symptoms when they first got it. Next, the herd immunity threshold is likely to be very high in most places, even if it exists at all. So we've seen in some places, for instance, in Peru and other places, in terms of when you look at towns where the total antibody test results are exceeding 70%. When you look at prisons, when you look at some of the ships that were hit early on, over 70% of the people were infected and demonstrated that they had an antibody response. So if we're looking for natural herd immunity, we're going to have to burn through a lot of people. A lot of people are going to get sick and die as a result. Forward, we've been really bad at protecting the most vulnerable, and so right now we don't know the best how to best do it. The only way we know how to protect the most vulnerable is to reduce the amount of circulating virus. So, for instance, Germany, which had a first wave, they had one wave where it went up, and then they immediately got it down very quickly in terms of the amount of circulating virus for SARS-CoV-2. They were extremely effective at protecting the most vulnerable because there was not very much circulating virus. The problem is that when the virus increases how much virus is circulating in a community, it's invisible, and it's really hard to protect those most at risk because you can't see it and you don't know. We can encourage people to do things, wear masks and stuff, but we haven't been effective. On average, most states, if you just look even alone, just looking at long-term care facilities, around 40% of deaths have occurred in long-term care facilities. These should be the ones that are most easy to lock down or somehow protect because they're in one place. They're institutions. Whereas other people with diabetes who are just walking around, they're taking if the diabetes is under control for most diabetics, they take medicines and it's fine. But if they get SARS-CoV-2, then their sugar might get uncontrollable or their insulin, and that really adds to the havoc of it. And so how do we protect people that are just walking around regularly because they don't have any symptoms? Or rather diabetics who are just technically diabetic on medicine, but they're just fine. So they would go to work, they're just like anyone else, but they just have this underlying condition that puts them at higher risk. Do we expect that diabetics or people with metabolic syndrome are just going to lock down for the next 6 months? I mean, it seems kind of ridiculous. That's why this idea of protecting the most vulnerable seems absurd. We can't ask people to quarantine just because they're overweight or diabetic or whatnot. And one of the logical problems with this is that if so, we know three, the herd immunity threshold, if it exists at all, it's likely to be 60-70% required to hit that herd immunity threshold. And yet we know among those at highest risk, around 50% of Americans meet that definition of high risk, according to the CDC. When you add up people over the age of 65, people obese, people with diabetes, with all these other comorbidities that we found that significantly increase the risk, you can't ever achieve herd immunity threshold just with 50% of the population that are at lower risk if the herd immunity threshold is higher. So that means that the Barrington Declaration requires us to purposely infect those who are, or de facto, maybe not purposely, but the only way for it to be successful is a requirement baked in to the Barrington Declaration that that the most high risk people get infected if that's what they're going for is herd immunity. And then the last thing here, the reason that we should not pursue it is that the infection fatality rate and hospital length of stay have been dropping dramatically each month due to better treatments, and we expect that they're going to continue to drop. I mean, just look at President Trump, who was infected with the virus. He allegedly had some severe symptoms at first, or was on track to have severe symptoms, and he was given this magic cocktail that he calls it in terms of the monoclonal antibodies, or in fact, the polyclonal antibodies he was given, the corticosteroids and remdesivir. We now know remdesivir is not as successful as we thought that it would be. There have been some new studies published in the last week. I won't get into it this week very much, but remdesivir doesn't seem to really be as effective as we were hoping it would be. The corticosteroids are still very effective, and the polyclonal antibodies are still in phase 3 clinical trials. But I'll just leave it there. So this is the summary of where we are at the Barrington Declaration. Now let me go into the responses. All right, so here is where we are. So the White House was widely seen as endorsing the herd immunity and endorsing the Barrington Declaration. In fact, Health and Human Services Secretary Azar held a meeting with Scott Atlas, who is on the coronavirus committee that's overseeing it, and they met directly with the authors of the Barrington Declaration. So they are meeting with very, very, very few epidemiologists out there, hardly any, and yet the ones that they met outside of the federal government, the ones that they agreed to meet with, are the folks who wrote the Barrington Declaration. Azar admitted in his tweet summarizing the meeting, we heard strong reinforcement of the Trump administration strategy of aggressively protecting the vulnerable while opening schools and workplace. In addition, Scott Atlas, again, who's on the this board of for the COVID-19 response in the White House, he said, sent out this tweet, looks like top scientists all over the world are lining up with Donald Trump. And so he was quoting the Barrington Declaration. In addition, then he implicated the World Health Organization and said the World Health Organization agrees with us. And that's not the case. In fact, here's further tweets. This is from Scott Atlas tweeting, who's on our government's oversight committee on how they're managing COVID-19, the epidemic in the United States. And this is what he's tweeting out of this agreement with the Barrington Declaration. Apparently, some of these meetings have been in off the record. And so they're not really telling us what's said. They're not really, there has been no formal announcement by Trump that they're following the Barrington Declaration. Yet all of these things are coming out from the folks on the committee overseeing it. And so now epidemiologists are responding. I'll get into that in a bit. But here's the World Health Organization. So at first, the World Health Organization said full lockdown should be a very, very last resort and can be avoided, which is true. If we require people to wear masks, we have a lot of investment in a lot of testing and tracing, contact tracing. If we do these other things that we know work, spending more time outdoors and more physical distancing 6 feet away, if we know that we do these things, then we should be able to avoid many lockdowns. And so that's why the World Health Organization was saying they should be a last resort. But then Scott Atlas was tweeting out, oh, well, see, it looks like the World Health Organization agrees with us. No more lockdowns. But that's not what the World Health Organization said. And so now the World Health Organization had to come back and very definitively say herd immunity approach to pandemic is unethical. In particular, never in the history of public health has herd immunity been used as a strategy for responding to an outbreak, let alone a pandemic, said the World Health Organization, one of these leaders. It is scientifically and ethically problematic. So this is definitive. There's no controversy here among epidemiologists. There's a fringe group that's doing this. And one of the key things that I want everyone to know is that epidemiology is a quantitative science. We communicate, the vehicle of communication among epidemiologists are quantitative models, research, critically evaluated research that's peer reviewed and that people can transparently evaluate for ourselves. We look at things like confidence intervals. So how confident are we with things? Doing sensitivity analyses and uncertainty analyses. We would do analyses of alternatives. So for instance, whenever you see models, you see, well, different scenarios, what will happen under different scenarios. And the people who wrote the Great Barrington Declaration have not done any models at all. Epidemiologists are saying, okay, well, it's great in theory, show us your work. And there's no model that supports it. What they're doing is just rhetoric and intuition pumps, and it's just words that they're putting out there. People who are not epidemiologists don't know what to interpret because they don't know that there's actually no data or facts or models underlying what they're saying. They're just people wearing an epidemiology suit without actually doing the work of epidemiology who are saying it. And so real epidemiologists who have been modeling this say, well, show us your model. And there's no model supporting the Barrington Declaration. All right, so next, let's leave it on that. So Beck, if you go on, there's a couple other questions with regard to this. So let's go one by one.
Okay, we'll go. Actually, I'm going to unmute Sandy Rock, who has a question, a follow-up question, specifically about Scott Atlas.
I got it, Becky. This is terribly upsetting, to say the least, but is there any way for scientists or epidemiologists? I know they try. I hear it on CNN and all the major networks. I don't know how other networks are, OAN is handling it or anything like that. But is there any way for people to come forth and really say, because he's now come out and said masks are not necessary besides the herd immunity. This is so dangerous, and it's holding us all back from opening up and getting out and doing and just licking this. So is there any way for any scientists or doctors to prevent this from happening? It's like calling reverse fire in a theater.
The problem is that's a really good question. The problem is that the public health community has spent billions of dollars over the years trying to prepare ourselves for an epidemic. And we've put all of our resources of the science, the top scientists, or many of the top scientists, the public health officials in terms of actually executing on things, the top communication experts in terms of public health communication. We've organize them all and put them in the United States CDC. And that was historically what was supposed to respond. And so it's as if we have a 10 alarm fire that's, or let's call it 50 states, a 50 alarm fire, but someone has shut off the fire alarms. And the problem is, if someone shuts off the fire alarms, there's no quick fix to that. We've spent billions over the years making our fire alarm system the best in the world. And if someone manually overrides it, it's hard to overcome it. But there are people that are trying. So we can't replace the CDC with sort of like just an ad hoc CDC of scientists, because we can't do this. There's too much infrastructure that's required, and it's all been put into this one set. The only thing we can do is hope that the next election in just a couple of weeks switches the management of the disease. People have lots of different reasons for voting one way or another, and I don't want to get into the politics in general. But when it comes to the epidemic in particular, Trump has failed declaratively by all scientists who are studying this and looking at it, or the vast majority of mainstream epidemiologists here. And there's no question here that if we want to just achieve the average seen in Europe, let's say, then we need to dramatically change our direction in what we're doing. We are far, far, far below average in the Western world in terms of the United States, how we've responded. We have had much more deaths and cases and severe illness. And it's just clear. So what some scientists have done in response to the Great Barrington Declaration, they've created this thing called the John Snow Memorandum. And so John Snow, I think I've talked about him before. He was considered one of the fathers or grandfathers of epidemiology. Essentially, during a cholera outbreak in England at the time, he identified that one of the ways that the cholera was spreading, or the primary way that the cholera was spreading, was from a water pump, where people were coming to get their water and they were dumping their old water in that, or for some reason the sanitation wasn't good. So that water at that pump was infected with cholera. So people who are filling up their bottles of water from that water pump were getting this contaminated water, and that was spreading the disease. So what he did was just simply disconnect the water pump part of it so that people could no longer pump the well, and that alone dramatically reduced the cholera epidemic in that area, because no one was then getting infected from the water. One interesting side note that he noticed at the time was that people in bars seemed to be getting cholera at a much, much lower risk. And that's because they were drinking alcohol in the bars and beer, and the alcohol was killing it. And so just the fermentation process. And so that was just a really interesting finding, that he found that, drink more beer as a solution to avoiding cholera. Don't drink water, drink beer. I like that. But so the John Snow Memorandum is now sort of real mainstream epidemiologists fighting back. And so their central conclusion is, for the concept of natural herd immunity, that it's a dangerous fallacy unsupported by scientific evidence. They published this the analysis with their references and people who signed it in the Lancet, which is one of the premier medical and epidemiology scientific journals out there. In contrast to the Great Barrington Declaration, which was, I think, signed at an economic think tank. This was in contrast published by one of the premier medical epidemiologic journals. There's a lot of people who are signing it now. More than 4,000 scientists, researchers, and healthcare professionals have now signed it. And so this is the primary way that they're competing with the declaration itself. It's just really hard because we don't have an infrastructure to communicate best practices outside of the CDC. It's taken years to set up the CDC and to make it the best in class in the world. And without it, there's no backdoor that we have to sort of compete with the US CDC now that it's been broken. Maybe in a later week I can talk. There's some really interesting articles that have come out talking about how the US CDC was broken. So what the Trump administration in particular did to break it and why it's no longer working. And so some of the things that we'll probably need to do to fix it when a new administration comes in. And so that is that. yeah, that was a good question. There is now momentum on the side of mainstream epidemiologists to combat it. So the problem is that the U.S. government is still supporting the Great Barrington Declaration in action, if not directly in words.
Thank you for that great follow-up question, Sandy and Glenn. Thank you for telling us more about this John Snow memorandum. So we know that alcohol kills germs on our skin, but this is interesting that John Snow, he was suggesting that people go out and drink more. Is that part of this conversation?
That was not his suggestion. It was an interesting insight, and
Oh,
was one of
okay.
the reasons that he realized that the water was spreading it. And so what he did, the intervention that worked, was simply unscrewing the water pump so that people could no longer go there. They would have to walk further distances to other water pumps to get their water, and those were not infected. And so literally he didn't have to go around telling people to wear masks or do any public health intervention, that the people had to change their behavior. This was seen as really great because it was a public health intervention that required no change of behavior among people. He just simply did it, took it, put it in his pocket. I guess it was big, so he just carried it under his shoulder and walked away, and that ended it, just based on that one intervention. So that's why he's become sort of the father or grandfather of epidemiology. Epidemiology has had huge advancements since then. It's now, over the recent decades, has become a modern science. Clinical trials, all clinical trials you hear about are epidemiology studies. So epidemiology includes all medical health studies on human populations. Outside of lab studies looking at cells and petri dishes and stuff, clinical trials looking at the distributions of disease and their determinants in human populations is sort of the core of epidemiology. All right,
so we won't take that leap quite that far then.
Yeah.
From John Snow, and continue using the alcohol in our hands. Okay, so thank you to everybody, by the way, who has sent in questions during the week. Glenn has built a lot of his conversation today based on those questions. Sorry, you hear my dog participating as well. Gotta love these Zoom calls. And if you have questions today, certainly send them to me privately in the chat, and I'll do my best to get them into today's conversation. And if not, I will share them with Glenn. So for next week, we can answer all questions. So we will continue on with a question about air humidifiers. So Glenn, you told us early on that we should all have pulse oximeters in our house, which I do. I have 2. I even have I have my main pulse oximeter and my backup. So we can all know our oxygen levels. So we have that. What's your thought on, do we need do we need humidifiers? I mean, what do we need to have on hand to really be effective in protecting ourselves?
All right, let me see if this is going to work. All right, let me know if you can hear this okay. Just nod your head, Rebecca, if you can hear this.
Researchers have used the Fugaku supercomputer to model the emission and flow of virus-like particles from infected people in a variety of indoor environments. Air humidity of lower than 30% resulted in more than double the amount of aerosolized particles compared to levels of 60% or higher, as seen in simulations released on Tuesday by research giant Riken and Kobe University. Their findings suggest that the use of humidifiers may help limit infections during times when window ventilation is not possible. The study also indicated that clear face shields are not as effective as tighter fitting face masks in preventing the spread of aerosols. Other findings showed the number of singers in choirs, for example, should be limited and spaced out. There has been a growing consensus among health experts that the COVID-19 virus can be spread through the air. The US Centers for Disease Control and Prevention revised its guidance this month to say the pathogen can linger in the air for hours.
All right, so that was interesting So let me just go back over here for a second. So, so I thought that this was a really interesting demonstration. We know from epidemiologic studies that aerosols do exist, and it's a potent way for SARS-CoV-2 to spread. What was interesting about this study that I just showed you, and the visualization, is that they used a supercomputer to really look in more detail at some of these things. It's totally consistent with the epidemiologic findings, but of interest is that they found that, so we found previously seasonal variation, that if you have very, very high humidity above 60%, that's really protective. What we're finding here in this study that's new is that as the air humidity goes down below 30%, it gets even more terrible for the aerosolized particles. They found that there's doubling the amount of aerosolized particles between 30% and 60%. And so what this would suggest is that humidifiers ought to help indoors in the coming months for people to have humidifiers, that if there is anyone who's infected and they don't know it, it could reduce the spread internally. So now this is not definitive. Again, this is just a supercomputer that's done this analysis. It seems reasonable, and a humidifier is a low cost, a generally low cost intervention. So this could be something for people to consider, just running humidifiers, trying to keep the humidity level in the indoors in the winter months, maybe higher than they would normally do it in other years, just because you can see that there seems to be an effect. And also this visualization, it's kind of graphic. So as we know, SARS-CoV-2 is invisible to the naked eye, and seeing the aerosols physically going across the room and hitting people on the face, I think really is very graphic for people, that people should be aware that this is how it's traveling. Back to you.
Thank you. That was actually quite demonstrative, but yet very appreciated. So kind of as a follow-up to that, we've been, talking about sanitizing a lot. And I think, and early on, I wonder if others on this call were wiping down groceries before bringing them into their house. And if maybe you've stopped like I have, but I'm wondering now if I should be doing that again. Is that over the top?
So so when the virus spreads through the respiratory route, these aerosols, that's what we're thinking is the vast majority of spread, through either aerosols or through droplets. This what's called fomite spread is when it's on surfaces. So even though we now know that the fomites can last on surfaces for many days at this point, many days. We thought that it was would not last so long, but now we know it could last for many days. It's unclear how long viable virus can last on some of this, but we know it could be quite some time. But what we're realizing is that the risk of getting infected from a fomite is very small. And so when we talk about grocery store packages or bags or other packages we might receive through the mail, it seems to be extraordinarily small. There might be some risk that still is there, but the risk is extremely, extremely small. So it's not something we need to do regularly. Really, the biggest things we need to worry about are the respiratory route. And so still not shaking hands with people anymore during the outbreak and things like this, so that we don't have this direct contact, but worrying about sort of the spread on like groceries and stuff is really not something we need to be worried about, like we were back in March or April, because we just didn't know any better back then. Back to you.
Thank you. Thanks for that update. Very helpful. And another question that came in was, could antimicrobial resistance get worse because of the wide use of antibiotics? Is there any correlation?
It's a really interesting question. So there's just a couple of things I'll say about this. It's something that some people have been researching, because as all of these people have been getting sick with COVID-19 around the world, as the lungs deteriorate and sort of become sort of this soup of cells that are just decomposing and stuff, and they get really sick, it makes it very easy for other infections to come in and take advantage of the situation. And so there could be bacteria that come in, people could get these other co-infections. And so as a result, a lot of physicians have been giving out a ton of antibiotics and antimicrobials to try to either prevent the bacteria from coming in or to treat it. And so there is a risk. My understanding of the antimicrobial resistance problem is that a lot of the antibiotics that are given out are actually given out to cattle around the country. And so I think that is where there's a lot of resistance growing. Then there's also in humans an excessive amount used where this is one of those big philosophical problems. So we know for any individual person, the risk of getting a mutation that causes resistance to an antibiotic is very low. But so for an individual, a lot of times a physician will say, okay, let's give them an antibiotic. But at a population level, if you give antibiotics regularly, then the risk that any resistance will evolve becomes very high. So it's one of these balancing acts. Well, for your patient sitting in front of you, do you give them the antibiotic, even though you know that at a population level, if every physician gave every person sitting in front of them an antibiotic, that we'd very quickly have a lot more resistance. And so it's a tough question. Most of the time we're saying people are getting antibiotics way too frequently. The biggest problem is that we don't really have a lot of drugs in the pharmaceutical pipeline for a backup plan. As antibiotics become less effective because the the microbes become resistant, there's not really any backup plan right now. So we could potentially be in some trouble. One solution that has just barely begun to be investigated are these things called phages. And I don't know if most people on the call are aware of them. Right now, they're not at a stage of clinical trial where we'd regularly be looking at treating anyone with it. But essentially, a phage is a virus that infects bacteria. We normally think of viruses infecting us, but viruses are very, very specific to the type of cells that they infect. And so every bacteria, as far as I know, has phages that attack them. And so these phages are extremely common out there. And so there's no theoretical reason why we can't develop phages for common bacteria, fungi, or other infections that then go and seek and destroy those bacteria within our bodies. And so this is really interesting. I'm looking forward to seeing more research on this area. It would require probably more challenging manufacturing, but it's not like all is lost. There's definitely things that could be studied if there is a will and there was sufficient funding to pursue it. But right now we are at risk, and their antimicrobial resistance is probably going to continue to increase on the short term. And so with COVID-19, the other thing, so right now I'll just say a couple of things. In the United States, more than 35,000 people die each year as a result, on average, from the antimicrobial resistant infections. That's just in the United States alone. The World Health Organization has declared antimicrobial resistance as one of the top 10 global public health threats facing humanity, or at least they did prior to COVID-19, but it's still one of the main ones. And one of the issues with COVID-19, with the pandemic, is that it's shifted a lot of people's focus to COVID-19. And so the worry is, will funding decrease for fighting antimicrobial resistance or for other things relative to COVID-19? And there are some burdens. We see in the malaria epidemic that's going on in parts of the world, or tuberculosis or HIV, that COVID-19 has really hit some of the people who are at risk for those diseases really hard if they're not going to get treatments if they're available, or vaccines if they're available, or other types of interventions. So this is something that a lot of us are continuing to pay attention to, but we don't have hard numbers yet in terms of the specific impacts.
Thank you, Glenn.
Back to you.
Thank you. Looking forward to hearing more on this in the coming weeks, but this is certainly very interesting. Sandy has a follow-up question about the movement of aerosols. So I will ask you to unmute.
I did, Becky. Glenn, somebody just told me about, now I'm in Florida and it's warm. So the tables at a restaurant are still spaced and distant. So that's fine. but somebody was just at a restaurant where inside the restaurant, it was packed, no separations. And they had extra fans, I guess, to circulate the air. And I'm wondering if that would be a simple remedy, then schools and whatever could just have exhaust fans in windows to take this air out, or will that just blow it up and spread it more?
So one of the early studies that we saw out of China was that if it's only recirculating the air, then as we saw in the video, all that would happen is that you're just moving the particles around and around, and so you're re-exposing the people. If what they're doing is actually have an exhaust fan that's removing the air from the facility and replacing it with fresh air constantly, then it would be a lot safer. The problem is if you have a lot of people nearby, you saw in the video that we just saw that people talking to each other, it's hard if you're nearby to avoid having these particles hit the person, because it's not even the droplets, it's the aerosols go much further, and it's just hard to avoid that. Even if there's airflow, it's going to be hard. The problem is that when people are indoors eating, it forces them to take off their masks. And so eating is not, we should be avoiding, anyone who really cares about not contracting the SARS-CoV-2 or COVID-19 should avoid eating in densely filled restaurants until this is over. There's just no way around it. Even if we were successful at having better air exchange, where we totally replace the air inside the building with outdoor air regularly, the risk is still going to be way too high. It wouldn't be worth it. Much better to eat outdoors, get takeout, have a picnic with the food rather than going indoors to restaurants. In fact, I suspect that we'll be seeing more restaurants closing, hopefully not closing completely, but having to shut off their indoor eating areas, at least in the northern parts of the country as it gets colder, just because it's going to be an increased source of spread. Yeah, there's not really any good way around that.
Well, I guess then the only good way around it is to really do our part in supporting these restaurants, right? I remember weeks ago you said to me, don't be worried, don't be upset about having to cook every meal. I actually should be supporting these restaurants, right? So
Sure.
it is really sad when you think about something like 80% of restaurants fail in just a regular time. Imagine what that statistic is going to look like now.
Yeah.
So thank you for clearing that up for us about the use of fans. Thank you for the question, Sandy. Arlene and Harry, I'm going to ask you to unmute. Please, you have a question about the sort of psychological fatigue of the moment and how many months we are, there you go, into this.
When you've presented a whole bunch of information about how the disease is transmitted and what the graphs are and how many people are going to get infected in the future, the one problem you haven't talked about is psychological fatigue and how that's going to interfere with bringing the virus under control. Assuming that we have national support in a month or two to change the dynamics of how we're going to approach this as a country, how do you get by the psychological problem of what's been created?
There's no easy answer there. One thing that I can look at is this. So this is mobility, how mobile different countries have been based on cell phones and other kinds of things. And you're right, there is fatigue. In the United States, because of our fatigue, we ended the lockdowns too early. So other countries like Italy, United Kingdom, were able to get their outbreaks under control because they locked down and then only opened up, like Italy only opened up after it was under control, and so they could come up to a much higher level. In fact, this is an indicator of economic activity because of people who are moving around in Italy could be more likely to go to restaurants and stuff because there was less virus circulating. Whereas in the United States, because of our fatigue with the virus, we never got it fully under control, and we've had this burn. So we never were able to get our economy back up to what it could have been because we've had everyone has this lingering fear and this lingering risk. There's no easy way around it. Plus the mixed messages. the fact that the top of the federal government and even folks at the CDC have been giving us mixed messages versus what the epidemiology community is saying we should be doing, there's no easy way. It's just exhausting just to figure out what's right, and without even knowing what the experts are truly believing, because of the mixed messages we're hearing. So I don't have any good response. It's problematic. It's tough. We all remember how tough the lockdowns were. Right now, here's our current projections on, this is from the Institute for Health Metrics and Evaluation. They've done a pretty good job for some of their projections in terms of looking at what they might be. Beck, you want me to jump into this? That was one of the other questions that were out there. So,
Perfect. Thank you.
so these are the states that they're looking at based on the current mobility that's there and the speed of the infection currently spreading. This is when they project that various states are going to be having new lockdowns, just based on the amount of cases and deaths that they expect in many of these areas in the coming months. You see some, like New Jersey and New York, are in green. They get hit hard early. That they anticipate there won't be any mandates before February 1st. We'll see, because part of the consequence of being hit early was that the government has been more responsive and more willing to shut down. So we saw in New York City, for instance, that there were some areas that had higher constraints put on them. So we might see more like that. But right now, this is one projection. Let me switch to looking. So this is another really interesting thing. Looking at the projections here, I'll get into a little bit more detail. But so basically, there were 3 scenarios that they looked at. One scenario was the base case, which they're calling the reference scenario, and that is where we continue on the same way we've been engaging with the management of the virus for the last 9 months or so, where we just continue on and we do status quo, what we've been doing. And if we continue on with that, then right now in October, we're at approximately a little bit over 200,000 deaths that have occurred so far, closer to maybe 220,000, a lot more if you include the undiagnosed COVID-19, just the excess deaths that we've talked about previously. But in their status quo, based on just current trajectory of what we're just doing the same types of things that we've been doing throughout the year, they expect that by the beginning of February, we'll have hit roughly 400,000 deaths. So almost double the number of deaths between now and the beginning of February. That's going to be a really tough, short number of months that we're about to see. They said that we could reduce that by around 100,000 deaths if we have mandatory mask wearing. So if they require that every single person wears masks when they go out, even for a second, and some people indoors wear masks, in their own homes wear masks, let's say, then this would reduce the deaths by 100,000 people. In contrast, if we followed the advice of the Barrington Declaration, which is mandate easing, so that there were no mandates at all, let people do what they want and protect the high risk folks, this focused protection that they were talking about. If you just did that, then what that would mean would be that there would be an additional 100,000 deaths over what the base case was by February. And so again, we're approximately 200,000 at the beginning of October here, or rather we're at the middle of October. So a little bit more than 200,000. We have a choice in front of us. Do we want to hit 400,000, which is what we're on trajectory to do right now based on what we've been doing? If we just continue on doing the same things we've been doing for the last 9 months in terms of our management of the disease, do we want to reduce it by 100,000 human souls, or are we willing to let even more people die, more than doubling the number between now and the beginning of February? And again, this doesn't just end in February. You saw at the beginning of our first surge, that didn't start until really the end of February. March, April is really when it started getting going. So this is going to continue through that. This projection just ends in February, just it didn't go further than that. So this is going to be really problematic. I can show you one other thing. I can go to this study directly. All right. If I can find it. So this was the study itself. Again, I am from IHME. They've done some great work. I'm going to just go to I think it was table 12 and 13. Some of these are just really interesting, looking at the age groups, but nothing new there. We know that higher age folks are at higher risk. This one is looking at the reproductive value, the same as the dashboards that we just saw earlier. The really interesting things come later on in some of the figures, so I'm going to jump to them. This is the current, I'll just very briefly, these are the current mandates in place state by state that are used for the projections, and the history of them in terms of where they were in different months and sort of when they ended. I'm going to just skip to this one. This is diagnostic. No, I'm gonna go to the the end, the projections. So we just saw this. This is the graph that I just showed you, but this is more interesting in some ways because this is the number of daily deaths. So at our peak, let me see if I can find this real quickly. That's here. At our peak, with the total number of deaths, what you can see here is that our 7-day average peak peaked just above 2,000. So let's call it, it was like roughly 2,100 or so was this peak in this first surge, 2,100 COVID-19 deaths. Now we're projecting that it's going to be roughly that amount by between January and February that we'll hit this peak again if we continue to do what we're doing. It's a longer peak, a longer surge than the first. So the total number of people that die are going to be more over the shorter period of time. But the total peak is expected to be roughly the same. If we start having masks regularly worn, we can reduce it, and so we won't hit the levels done in the first peak. If instead we do the Barrington Declaration approach, where it's just sort of this focused prevention, and we let far more virus spread in the country, then we could expect potentially a daily death rate exceeding 5,000 deaths per day, in contrast to the roughly 2,100 that we saw back in March, April, May. So this is a decision. I think one of the reasons that February was put in here as the contrast was the assumption that if we had a new president that came in, that we could dramatically change things at that point. And so that because there was such a difference that could happen, it's very hard to project what's going to happen after February. If Trump continues and is reelected, then whatever curve we're on with Trump is just going to continue on that curve. And so this is what we have there. All right, back to you.
Thank you, Glenn. Thank you for all the great questions that everybody submitted earlier and joined into the conversation tonight. And next week, we're going to begin with a great question from Sarah Yora about schools and an article that Emily Oster wrote. I'm sorry that we're not able to get to that question tonight. We're just about at our time here, but please stay tuned for more on schools next week. And keep the questions coming. It's really helpful in order to prepare for the conversation. If you send in questions during the week, that is fantastic. And of course, Glenn is always happy to take questions as we move along. So everybody continue to wash your hands, wear your masks, get a pulse oximeter and a humidifier if you don't already have one, and be well, be safe, and looking forward to seeing you next Sunday. Thank you so much, Glenn. Really always appreciate it.
Thank you very much, Rebecca. And thanks everyone for joining us. See you next week.
Bye-bye.
Bye-bye.